Okay, my name is Aidan Daly, and I have been in practice for just over 40 years as a GP, working in the beautiful county of Kerry. I'm also what's known as a gypsy GP, that is a GP with a special interest in rheumatology and musculoskeletal medicine. So the keystone to any good consultation is the history and physical examination. And today we're going to discuss these concepts relevant to rheumatology. So the history, basically you are familiar and taught in medical school about the traditional history, which involves the presenting complaint, past medical history, the family history, social history, occupational history, allergy history, and current medications, etc. So you're all familiar with that. The other concept is the Calgary-Cambridge method of consulting with patients, which basically is a revised version particularly suitable for general practice in a specified period of time, and it's basically used as a different modem of communicating with the patient and trying to get the patient involved in the consultation themselves. And it consists, as you know, of the initiation of the consultation, which is really what we refer to as the golden minutes of the consultation, where you introduce yourself and you empathize with the patient and you set the agenda for the rest of the consultation, which is really very important. That's followed then by the process of information gathering, and then we follow that by the physical examination, which is followed by the explanation and planning, and then we have closure, which is a really important part of the consultation in terms of safety netting everything that's happened before. But there's also a more specific part of the consultation, especially when you're dealing with different systems, and in this case in rheumatology, this is what we call a sort of a more highly selective form of history that we have to obtain from the patient from the rheumatology perspective that we're dealing with. The first thing we have to establish really is the dominant hand or leg, and we're going to actually refer to the shoulder joint we'll use as an example in terms of demonstrating what we're saying. So you've got to establish, is the patient right-handed or left-handed, which is the dominant limb. The second thing is that we want to know, are the symptoms unilateral or bilateral? The third thing we need to know is we need to discuss the pain, because pain is really the key presenting symptom of any rheumatological complaint. And it's the primary symptom that we're going to deal with. So the issues regarding pain are, we want to know, is the pain of sudden onset or gradual onset? In the case of the shoulder joint, sudden onset would be somebody, for example, who presents with acute shoulder joint pain where they have subacromial bursitis or acute calcific tendonitis, in contrast to somebody with gradual pain where they have basically an impingement syndrome or adhesive capsulitis. We also need to establish whether the patient has pain at rest or on movement. This is very important in rheumatology, because in shoulder pain, again, with acute subacromial pathology, the patient will find it very difficult to move the shoulder joint, for example, with acute septic arthritis, in contrast to somebody with, say, an impingement syndrome, where there will be painful on movement, like in the painful arc. We then have to establish whether the pain is intermittent or constant. Again, that's important. And we then have to establish the site of the pain, which is very important. In shoulder joint, for example, if the patient complains of pain at a specific point, like the acromioclavicular joint, that is where the pain is. Usually, sometimes with shoulder joint pain, patients mean that they have pain here in the suprascapular area. Usually suprascapular pain is pain emanating from pathology in neck. With shoulder joint pain, patients present with pain right on their shoulder. And it can often radiate down through the anterolateral aspect of their upper limb, sometimes to the base of their thumb. And the reason why that happens is because the shoulder joint is supplied by which dermatome? C5. Okay? So, and then the final aspect in terms of establishing the symptom of pain, we've got to establish, has the patient got night pain? Night pain is a really important symptom to establish that the patient has, because it's always pathognomic of pathology in the shoulder joint. So establishing whether the patient has night pain is also very important and a key issue. Now, apart from the pain, then we've got to establish whether the patient has stiffness. Patients interpret stiffness in different ways, but generally the stiffness, for example, in your lower back is usually early in the morning, can last for anything from 15 to 60 minutes. Usually the longer the stiffness that is present, usually it indicates that there's probably pathology in situ. The next symptom in rheumatology is swelling, and we're going to come back to that in a moment, but it's a key symptom that patients complain of, swelling of any joint. It's very important when the patient mentions that their joints are swollen, that you actually confirm yourself that the joint is swollen. If you find that the joint is not swollen, you have to bring the patient back to demonstrate to you when it is swollen, because joint swelling always invariably indicates pathology, and we'll discuss that in a moment. The other symptoms are the functional disability related to the activities of daily living. In the shoulder joint, for example, if the patient's dominant hand is their right hand, they comb their hair, they wash their teeth, they put on their coat, etc. So we have to establish, if the activities of daily living are affected by the actual pain that the patient has. We then need to establish whether it's work or sports related. We would also need to clarify whether there are any systemic symptoms. Is the patient feeling unwell, lethargic, fatigued, feeling sick, etc.? Are there any rashes or mucosal ulceration, which you can often get with diseases like lupus, for example? Is there any past history of arthritis, which is important to establish? And of course, is there any family history of arthritis? So they're really the main components of the history, with a specific emphasis on the history related to a rheumatological complaint.